Passive smoking, also known as environmental tobacco smoke or ETS. Passive smoking and lung cancer. Meta-analysis found that exposed workers showed 24% increase in lung cancer. Even dogs whose owners smoke are at a 50% greater risk of developing lung cancer. A study conducted in Japan compared non-smoking wives of either smoking or non-smoking husbands. They followed 540 subjects over 14 years. The wives of heavy smokers had a higher rate of lung cancer than did the wives of husbands who smoked little or not at all. These women's risk of dying from lung cancer was between 1/3 and 1/2 of what it would have been if they smoked themselves. Passive smoking and heart disease. More recent attention has been focused here. Heart disease claims many more deaths from passive smoking than does lung cancer. What is the mechanism? Passive smoking reduced blood's ability to deliver oxygen to the heart, making the heart less efficient. Also tied to higher levels of carbon monoxide in the blood. Passive smoking increases platelet activity. Passive smoking increases tissue damage following ischemic heart disease and myocardial infarction. Passive smoking may reduce people's ability to exercise. A study of healthy young adults found more early signs of artery disease in 15 to 30-year-old non-smokers who'd been exposed to smoke for at least 3 years. Passive smoking and the health of children. Infants exposed continually to parental smoking absorb the constituents of tobacco smoke, as measured by urinalysis. Babies of smokers were found to have greater incidence of respiratory symptoms of bronchitis and pneumonia compared to controls. The negative effects seem to diminish as children pass age 2. Stoddard and Millard, in 1995, found that children whose moms smoked had increased risk of wheezing respiratory illness, such as asthma, and symptoms of asthma were exacerbated if the parents smoke. Parental cigarette smoking may lower cognitive performance among adolescents. The likely mechanism is that carbohemoglobin is increased by exposure to tobacco smoke, reducing O2 capacity of blood and increasing carbon monoxide levels, which inversely influence mental performance. Why do people continue to smoke? Note, people smoke for a variety of reasons. Tompkins, in 1966 and 1968, hypothesized 4 types of smoking behavior. Habitual. They may have begun for different reasons, but continue because it's a habit. They are often unaware that they've lit a cigarette. Positive affect. They seek to increase stimulation, to feel relaxed, or to gratify sensory motor needs. Leventhal and Avis in 1976 dipped cigarettes in vinegar so they tasted bad. Those who smoked primarily for pleasure smoked less. Those whose smoking was not motivated by pleasure smoked the same number. Negative affect. They smoke to reduce feelings of stress, anxiety, fear, and guilt. The timing to quit may be more important than the method the person chooses. In a study of more than 600 college students, the overall success rate in quitting over an 18-month longitudinal study was only 18%. However, those under the least stress in academic and personal lives when they tried to quit had a success rate of 52%. There have also been some links found among smoking, depression, and stress. One study followed adolescents over 8 years to assess the rates of depression and smoking. Male adolescents who reported more depression were more likely to smoke. Addictive. They are not only aware of smoking, but also keenly aware when not smoking. They know how long it's been since their last cigarette and how long till the next one. Models to explain smoking. A combination of these models yields useful explanations for both initiation and maintenance of smoking behavior. Nicotine addiction model. This model suggests that individuals continue to smoke to maintain adequate level of nicotine and to prevent withdrawal. This theory offers better explanation for maintenance of smoking than for initiation. Research demonstrated that different nicotine levels made a difference in smoking rates for every participant. On average, they smoked 25% more low nicotine than high nicotine cigarettes. Smokers took more puffs from low nicotine cigarettes than from high nicotine cigarettes. This model does not explain why people start or why some people are heavy or light smokers. If nicotine were the only reason, other models of delivery should substitute. Experiments with the patch, intravenous, and with nicotine gum indicate that although they decrease smoking when nicotine was available through these other modes, individuals still have difficulty stopping smoking. If non-nicotine cigarettes are all that are available, smokers will still smoke them. Social learning model. This model suggests that individuals learn patterns of behavior because they are reinforced in some manner for those behaviors. Why do they continue with so many negative consequences, such as coughing, dizziness, watery eyes? For those who continue, the reinforcement value of smoking outweighs these negatives. For example, for adolescents, being accepted and cool may outweigh other negatives. Initial smoking may be negatively reinforcing if it removes unpleasant stimuli, such as a fear of being regarded as a chicken or a nerd. Deterring smoking. Information alone is not an effective way to prevent adolescents from starting to smoke. The DARE program does not work. Why not? What is needed to be more effective in deterring smoking? Why is smoking so hard to change? Several factors make smoking resistant to change. People smoke for different reasons, and these motives seem to be independent. Therefore, a single intervention cannot address all of them.